When we do an evaluation of the patient for reflux, one of the most important parts is to determine whether there's a hiatal hernia or not. We published a paper in 2011 that showed there's a significant difference in outcomes if there's a hiatal hernia and you don't repair it when you use TIF. So for sure, if it's there, you want to repair the hiatal hernia. The next question that we have to ask ourselves is, okay, well, we have this opening and it's getting bigger and bigger and bigger. At what point does that become significant? At what point do you repair it? And so there's different ways of classifying that. There's axial displacement. How far above the diaphragm is the junction of the esophagus and the stomach? There's transverse diameter. So the hiatus is an oval and we go by the greatest transverse diameter. And then there's Hill grade. So Hill grade came out in the 1970s, and basically you take a scope and you do a retroflex view and you grade what it looks like. Normal would be a Hill 1, a slight dilation would be a Hill 2, a bigger dilation that kind of opens with the respirations is a Hill 3, and then a fully formed hiatal hernia is Hill 4. So I think historically people would say there was only a hiatal hernia if it was a Hill 4. Fairly quickly, we identified that that wasn't the case. That people that had a TIF, and they hit a Hill 3, would get recurrent reflux about 50% of the time. So then the question was, well, between a Hill 2 and a Hill 3, when should we repair? And the problem was we studied the way in which Hill criteria are graded by different practitioners. And we found that there was a lot of discrepancy. In other words, one doctor would say this is a Hill 2, the next doctor would say this is Hill 3. The next doctor would say it's a Hill 4. The next doctor would say it was a Hill 1. So there's very little agreement among those stages. Although if you read the definitions, they seem like they're pretty straightforward. In practice, we're not able to come to agreement amongst physicians. So then we started doing measurements using a retroflexed vision of the opening, and we would compare diameters to the scope. Pretty quickly, we realized that there's an optical illusion to that depending on how close or how far you are to the hiatus. So the next step we took is we would retroflex the scope, and we can measure when that's retroflexed what the distance is between the outside of the tip and the outside of the body. And that turns out to be, for at least the scopes that we're using, 3 centimeters. But there's also kind of a loop to it where the widest diameter is 4 centimeters. So if you withdraw the scope into the hiatal opening, you can actually use that as a reproducible measuring device, where if you could get the tip of the scope in, it's 3 centimeters. If you could get the whole scope in, it's 4 centimeters. If it slides in easily, it might be 5 or 6 centimeters. And then you're estimating again. But we know at least that if you can get the tip in and it's 3 centimeters, those patients will need a repair. And right now, that's the standard we're using for measurement, mainly because it's reproducible.